doing a very nice job. And I would now turn over the mic to Dr. JP Leong.
Thank you, Dr. Presented this morning. The topic of the case is a case of paraplegia T4 secondary to spinal cord compression from Pott's disease. This is a part of an ongoing series for pediatric Pott's patients presenting in the cervical and upper thoracic spine segments, to be presented by Dr. Bienvenido Caro of the Philippine General Hospital. So, Don, the floor is yours.
I can mention that. Yeah. My
hyperreflexia of the knee and ankles for both lower extremities. Ancillary tests were requested, and sorry for the small table shown here, but this just shows the sensitivities of the ancillary tests that we would request for Pott's disease. The AP and lateral x-rays for this patient, the lines for the AP view show that there is lateral translation at the level of T1, and the spinous process are not midline. Despite the swimmer's view, it's hard to see, but there's actually a kyphotic deformity at the level of T1. And this can be better seen in the MRI, which I will be presenting later. So, remembering our spine at risk signs. So our patient has posterior retropulsion. He has no separation of the facet joints. The patient has toppling. So he has 3 of the 4 spine at risk signs. And studying the MRI, we can actually see signal changes here at the level of C6 and C7. This is the T1 vertebral body. The intervertebral disc is relatively spared, and we see a peridiscal presentation at the level of C6 to T1. And we have compression at the spinal cord. For the axial view, it's hard to see the rest of the anterior portion of the spinal cord, but you can see already compression at the level of T1 for the spinal cord. These are the proximal and the more distal cut. We can also see the signal cord changes at this level. So at this point, the diagnosis for this patient is paraplegia, last normal T1, secondary to spinal cord compression from Pott's disease. He was still a Frankel B given the sacral sparing from S2 to S5. So this patient was actually already advised surgery at this point for deformity correction and to improve the recovery rate. However, he could not obtain consent for this patient, and he was still on constant follow-up with our clinic. And actually 3 months after, the patient was already ambulatory, despite the still observable kyphotic or gibbous deformity at the cervico-thoracic level. And upon doing repeat neurologic examination, we can see that there's improvement from T2 to S1, from 0/2 to 1/2, and both lower extremities for this patient had improved motor output from L2 to S1. Sphincter tone was noted to be improved, and then reflex actually improved to normal reflexive manner. Repeat x-rays for this patient, you can actually see consolidation at the level of T1. Spinous process is already midline, but we can still see the toppling and the posterior retropulsion of the involved vertebral bodies with no separations of the facet joints. Or again, reviewing the spine at risk signs, patient still has 2 out of the 4 spine at risk signs. So at this point, patient has improved to paraparesis, last normal T1, secondary to spinal cord compression from Pott's disease, now a Frankel D. He is going category 1A treatment. And for Pott's disease, as we all know, most common locations are the thoracic and the lumbar level. So these are just 2 cases, one for a 46-year-old male who underwent posterior decompression instrumented fusion 2 up, 2 down, and another for a 34-year-old female. Both of these patients improved from Frankel B to Frankel Ds. As you all know, the cervical and sacral areas are rare locations for Pott's disease, and for the cervical area of Pott's disease, it usually presents as an extensive disease with large abscesses with a low incidence of paralysis. And for Pott's disease of the sacrum, it's more localized with less pus, but paralysis is more common. So just reviewing the treatment that the patient underwent for Pott's disease. So for surgical treatment in Pott's disease, there are 4 indications that our textbook would prescribe, and these are the following. Patient actually still falls for stabilization, and in the goals of the surgical management for this patient only is to treat the spinal deformity and for the stabilization. Another point for discussion would be what would be the type of approach that we could have used for this patient should he have consented for surgery. So these are just 2 journals, and summarizing the 2 and narrowing it down, they said that surgery is indicated for panvertebral disease. So that means there are 3 column involvement for the affected vertebral body level. For long segment diseases, so that means vertebral body level involvement of more than 2. And for correction of the kyphosis, usually greater than 30 degrees. Another table was cited by these authors. And for stabilization for patients with Pott disease, if the patient has positive spine at risk signs, or multi-level or panvertebral disease, or a patient actually would have fallen under this category. And for doing anterior-posterior combined approach, we all know that for short segment disease, we go with the anterior. I may be wrong, but most spine surgeons are also familiar with the posterior approach. And for the combined approach, the posterior portion can be used for the deformity correction. So I found this journal because most of the other Pott's disease journals focus on the thoracic and lumbar spines. I found a journal focusing on the cervical spine of cervical spine location for Pott's disease. And actually, the author divided it into 3: atlantoaxial, subaxial, and cervicothoracic. So our patient falls under cervicothoracic, wherein had surgery been done, a combined approach would have been best. And then these are just the radiologic parameters for treating the said categories. So plan for this patient initially was to do surgical management via a combined anterior and posterior approach. And to be able to do the anterior approach, you would have to check for the relation of the patient's vertebral body affectation in terms of the manubrium or the sternum. And then for the posterior approach, you usually need to stabilize 2 levels up and 2 levels down. So unfortunately, we could not still get consent for this patient to do surgery. But at the start of 2020, our institution actually noted an increase in the number of cervical and cervicothoracic Pott's patients. So as of this moment, we already have 10 cases diagnosis with Pott's disease in the upper cervical, subaxial, or cervicothoracic region. 2 were managed surgically. So 1 patient was a C1 vertebral body lesion of Pott's disease wherein an occipitocervical fusion was done. And another was a C6 vertebral body affectation of Pott's disease wherein instrumented fusion was done from C3 to C7. Information that we would want to obtain from this series would be the type of procedure, if any was done, the type of immobilization, the Frankel grade improvement, with or without surgery, and the pattern of the vertebral body involvement. Would it be more of a peridiscal, a central, or anterior affectation? And would it correlate and would it be similar to the classic Pott's disease that we see in the thoracic and lumbar spines? So sorry for the small text, but this is actually the ongoing database for the Pott's disease patients. Thank you.
Thank you very much. Although anecdotal, a lot of TBC, particularly during the era of COVID, when they're none. So we'd like to open the floor to any questions at this point in time. Yeah, Tommy.
Thanks for your presentation. You were reporting improvement neurologically.
Yes, sir. After 3 months of anti-cox treatment, sir.
How urgent is it to do the reconstructive surgery?
For doing reconstructive surgery in pediatric patients diagnosed with Pott's disease, the main complication that you would have to watch out for would be the late onset paraplegia from the kyphotic deformity, sir. For this patient, sir, the kyphotic angle has improved to 32 degrees, sir, from an initial 56 degrees.
What's the disadvantage of doing your reconstructive surgery at this stage? Your patient's 11 years old. What I'm trying to drive at is, can you delay with doing that? I mean, and just monitor for if the neurologics continue to improve, and then do the reconstruction at a later date rather than pushing for surgery at this stage.
Yes, sir. Actually, sir, we will have to monitor for late onset paraplegia due to the deformity, and once the patient has matured, we can go for the reconstructive procedure.
Yeah, well, that's my opinion. No? So depends on, of course, what your consultants also would like.
Thank you, Jomik. Any other questions for Dr. Caro? Romel.
Hello. Thank you, Don. In Raja Sakaran's, di ba, spinatrist, di ba, the younger the patient, the more prone to, am I right? The more prone to progression of the kyphosis, the toppling, and so forth. So, why do you think the kyphosis improved? Tama, no? You said the kyphosis improved.
Yes, sir.
Just by anti-cox.
Yes, sir. With the anti-cox medication, sir, there is noted consolidation of the pathologic area. There is noted improvement of the structure of the vertebral body, decreasing the kyphotic deformity and pushing the vertebral body in losing the kyphosis.
So there was a growth of the anterior structure, kaya?
Yes, sir.
Okay, thank you.
We have a question from Dr. Ver.
Question and comment. As far as Dr. J.P. Leung's statement that it seems that during this pandemic, there is a resurgence of TB. And in our experience, okay, that's correct. We rarely, in my practice, rarely pupunta sa amin in my place of practice, TB, unusual. But in the past 3 to 5 years, I am surprised that we are getting lot of TB, and not only TB na ordinary, usually, yes, cervical, thoracic, and the like. So that's been a observation as far as our practice is concerned. But my question to Dr. Caro, this is a ongoing, isn't it?
Sir.
Prospective study as well?
Yes, sir.
So in your cases, are you seeing just isolated level, whether it's but contiguous multi-level, or you're also seeing multiple levels in your cases? Because in my observation, that is what I'm seeing lately, multiple, not just like cervical thoracic, there's another level down and up below. So what is your, at least your series now?
Yes, sir. For the atlantoaxial patients, I've seen that most of them are actually isolated to one level. But for the subaxial and the cervical thoracic patients up to the level of T2, most of them still present with the contiguous vertebral body involvement of at least 2 levels.
None, like not contiguous multi-level, none?
None, sir.
Okay,
Yes,
thank
sir.
you.
Thank you. Any more questions from the body? Perhaps we can ask Dr. Chongsam, experiencer with cervical POTS in children.
Well, as as they said, TB is a very protean disease, so it could happen anywhere. Now, the incidence for pulmonary and extrapulmonary TB is almost the same. Okay, but what we're most aware of is pulmonary TB. So when you tell people it's TB of the bones, sometimes people get confused. Now, the incidence for TB of the spine and TB of the hip is almost of the same incidence. Now, for experiences on Pott's disease, I think you just dig into the literature, the papers presented by the Hong Kong people from the late 50s, 60s, and 70s. We have a lot. I have presented our experience at orthopedics in 1985 in Japan, so that's about 35 years ago. And we have done more than 1,200 cases. So the incidence compared to the one presented in Hong Kong is almost similar. Now, what is important is for TB is the medical treatment. It is very important. Even though if the patient cannot be treated surgically for whatever reason, sometimes the patients refuse, sometimes for financial constraints, whatever religious belief, etc., the patient invariably will improve. Now, as for the cervical thoracic, that's where there's a very nice monograph from Hong Kong, radiologic manifestations of TB. Okay, the cervical thoracic area is very typical here. The C7 will fall forward. There will be an acute kyphos. But just give a very small space for the nerve root to recover. Usually they recover if they are treated medically, because the cause of the paraplegia partly is from the inflammation, the edema. Now, if you treat the disease, the edema will shrink, so that will give the cord ample space to recover. Now, I always remember when I was a fellow in Hong Kong, the visiting professor from London always said, remember, millions of years ago, there was no doctors, yet people managed to survive. So that means nature is very forgiving. Okay. Now, as for the reason for the improvement of the kyphosis, it's because of of the natural law, because the patient is paraplegic or paraparetic. He lies down. What happens when you lie down? The head falls flat. So by gravity, the cervical spine will just gradually correct by itself, because the spine will also fall down, so the kyphosis will become less. Of course, we have to remember there are two types of paraplegia: paraplegia of active disease and paraplegia of healed disease. Now, what we are worried now is the paraplegia of healed disease. Now, as mentioned by Jomi, these patients can wait because he is showing signs of improvement. Now, the treatment for, before we go into surgical treatment of TB, you must load the patient first with anti-TB meds for at least 2 to 3 weeks. Because if you are very aggressive, just go in immediately, sometimes you'll cause a miliary spread. No, this was not emphasized, but you have to remember that. So in my very limited experience, I think that's what now, usually, if you read the paper by Thule, by an Indian, there's the middle path. Okay, if you are not trained surgically to do it, you can treat the patient conservatively. So not all Pott disease needs to be surgically treated. Okay.
Thank you so much, Dr. Changsam. And I guess 1,300 cases is not limited experience. No? So thank you for that. Any more questions from the group for Dr. Caro? Yes, we have 1 minute. Okay, if not, we'd like to thank Dr. Caro for his presentation this morning. And I'd like to call on Dr. Mike.